Well, if you look in the book, it says evaluation and treatment of a small posterior. So if you're looking for the plastic surgery conference, it's down the hall. But thank you for coming. Thanks for the introduction. I think a lot of these things that I'm going to talk about have been considered already, but just like to talk about a posterior fossa and how it relates to Chiari I and Chiari I. When I was thinking about this, I wrote down what I wanted to explain, and I thought about Lucy. I say, Lucy, you have a lot of explaining to do. And I know Ricky Ricardo said that. So I have to explain about the posterior fossa, and that's this area here, and the foramen magnum is there. And I want to explain what is a small posterior fossa, who are affected, how it develops, where in the posterior fossa is affected, either the entire posterior fossa or just around the foramen magnum, why this is important, and what to expect if you have a small posterior fossa. All right, so here's the posterior fossa on a skull, and you have the foramen magnum here, and this is the lateral extent. From the back, it goes to here. But actually, it goes up to the clivus, but it's I didn't want to confuse things. And then this is the inside dimensions. And basically, I mean, I should stop my talk right now, but a small posterior fossa is one that's too small to hold the brain structures. I mean, it's like having your pants are too small or your shoes are too small. It's just you have a little, this is like a protuberant belly, you know, you just don't have enough space, and so the extra brain, in this case the cerebellar tonsil, goes from the small posterior fossa and it goes into the spinal canal because that's the only place it can fit. I'd like to talk today about some of my collaboration with Dr. Enver Bogdanov in Russia. And obviously there's a lot of stress there because of the war, but people continue to get sick and he continues to treat them. So he's a neurologist and he sees about, his area covers about 1 million people in Russia. And this would be a normal posterior fossa here. This would be a Chiari I with no syrinx, and then this is a Chiari I. And we're going to be talking about a small posterior fossa, but I just want to point out, hey, you know, if you were a tailor, you would say, hey, you know, I made it big enough. You just didn't use the top part. And that's some of the controversy about a small posterior fossa. It looks like it's big enough, but either the lower part of the posterior fossa is too small, or it seems like the tonsils fell through the foramen magnum at one time and they just never made it back up. So in one area of Russia where Dr. Bogdanov goes, he had this group of patients. He had a mixture of patients with Chiari I and Chiari I, and I'll define Chiari I a little more later. But you could have no syrinx, no Chiari. You could either have short bones or normal bones. You could have Chiari with a syrinx. Most of those people had short bones. You have Chiari without syrinx, just short bones. Some of them had normal sized bones. But you can have a syrinx without a Chiari. This would be a Chiari I. Almost all of those, 7 out of 8, had short bones. So that was his group. So you could have a Chiari I, you could have Chiari I, you could have Chiari I. And when you have Chiari I, mostly with a syrinx. I'd like to go in, and I know there's going to be a talk on the genetics later, but let me just go into this. With the development of the skull, the top part of the skull develops through these sutures, you know, by the soft spot in the head. The bottom part grows through cartilage, and that's replaced. And pressure makes the top part of the head grow. Genetics and replacement of this cartilage by bone makes the lower part of the head grow. So they have two different processes, and that's why genetic influences affect the bottom of the head. And this is an extreme example when you have achondroplasia. You can see the top of the head is normal size, but the lower part of the head is smaller because that requires cartilaginous growth, and the body is also smaller. That's a dwarf. But let's get back to the Chiari group. And the dwarfs, achondroplastic dwarfs, can have Chiari because their posterior fossas are small. But in people who don't have known genetic causes for their Chiari, there's about a 12% chance that they will be from a family where there are other people in the family, first-degree relatives, that will have Chiari. And this is from Dr. Millerot's study in 1999. And so in him examining 364 people, 43 of them had a relative with Chiari. So in these cases, it seemed like there was some inherited element. Dr. Bogdanoff, again, he had some families where it seemed like Chiari ran in the family, and we examined them. You can see here's a father and a son affected, and then you have some brothers who are brother and a sister who's affected, but they didn't pass it on to the next generation. Here's another example. This person passed on Chiari to the next generation. This person did as well. So the more people who are affected, and I know Allison will talk about this, the easier it is to find linkage, the easier it is to find a genetic link to the Chiari malformation. All right, so most of the time we look at these sagittal MRIs to determine if the posterior fossa looks small. And it's this pentagon here, and that's the posterior fossa from the side. It looks like that. And either the whole pentagon can be small, or most often the lower part of the pentagon is small. And I'd just like to go into some of Dr. Bogdanoff and my research recently. He did a study of 120 patients. 30 were a control group. They had normal MRIs. 30 had a small posterior fossa, and the tonsils didn't go down very far. 30 had small posterior fossa and 5 millimeters of tonsillar ectopia. That means they had Chiari 1. These people had small posterior fossa, Chiari 1, and a syrinx. These people had small posterior fossa, very little tonsil. It didn't have Chiari, but had a little bit of tonsillar descent, and had a syrinx. So he had all these groups. He wanted to compare how they were different. And all of them were symptomatic. And so you say, well, how can somebody get a syrinx if they don't have a lot of tonsillar herniation? Well, what they do is they have this thing called Chiari 0. And that's really, on the sagittal, you really don't see it that well, because here's the tonsils. They just right at the foramen magnum. They don't really go down. What you need what's called an axial cut, and that will show the tonsils going around the brainstem, as someone asked a question earlier. That's what happens. Most of the time the tonsils go down, but if it's tight, sometimes the tonsils wrap their way around the medulla, and that can cause some cranial nerve findings. And Jeff Greenfield from Cornell described that. So anyways, Dr. Bogdanoff's study, what he found is essentially you have a smaller posterior fossa, but really most of the smallness is in the lower part of the posterior fossa. And it's more extreme if you have Syringomyelia. And Those were his main findings, basically. And he found that if you had a syrinx and you had Chiari 0, you were more likely to have a narrowing in the cervical spinal canal as well. See here, this would be 17, this would be 19. So it's not, if you have Chiari 0, you say, well, I have bad luck, my skull's a little small, but it extends into the cervical spine. The cervical spine's affected too. So, and at the top part of the cervical spine, at the craniocervical junction. So again, normals like this, Chiari 1 here is no room here, and you have a syrinx, and then this is Chiari 1 malformation with the tonsils 5 millimeters below the foramen magnum. Okay, so you say, oh, I don't really believe in the small posterior fossa. Well, if one piece of evidence that might convince you, though, is here, this looks tight to me. You see the white here? That's the white signal. That's the cerebrospinal fluid. Here's white inside the spinal cord. That's a syrinx. So things are tight. Here's the tonsil here. If you do a surgery and you expand the posterior fossa, the tonsils go up. You don't have to burn it. It's just that the cerebellum returns to a normal configuration just because it has more room. So that was convincing evidence to us in this study, at least, that the cerebellum and the tonsillar herniation come from a tight posterior fossa, not from a developmental problem of the nervous system, but really a developmental problem of the bone. And we looked at the relationship of tightness, in other words, how big the posterior fossa was compared to the rest of the brain. And we found that when the posterior fossa was very small, we would get the tonsillar herniation. But when the posterior fossa was larger, where the proportion was like 0.16, 0.17, then you would get less tonsillar herniation. So this is more evidence that the tightness of the posterior fossa causes the Chiari malformation. And it also causes tightness of the CSF pathways. And the tightness on the CSF pathways, that's important in the pathogenesis of Syringomyelia. This slide is from Dr. Batzdorf, from a chapter in a book. And he says, well, here's your underlying pathology, whatever that is, a genetic cause or whatever. Then the hindbrain's affected. You have local pressure. The pressure's on the dura. The dura has sensation that refers to the back of the neck, so you get occipital headache. So that's when you have the neural elements affected, then you can have all the bulbar, the sleep apnea symptoms that we were hearing about, but other things, vestibular, auditory, phonation, swallowing problems. And then you can have long track signs, and some of these are related to Syringomyelia. Some can be just compression. And you can have obstructed CSF flow, and that will cause Valsalva headaches. So all this fits together, really. I should say some people, as I showed with Dr. Bogdanov's study, some people have a normal size posterior fossa, and they're fine. Some people have a small posterior fossa, and they're fine. And the same thing can be said about tonsillar herniation. You can have tonsils that are 5 to maybe 13 millimeters below the foramen magnum. You can be completely asymptomatic. You can have tonsils 0 to 5 millimeters below the foramen magnum and become symptomatic. But these are called Chiari 0 patients. These are called Chiari 1 patients. The important thing is, if you have symptoms and they're severe, they're affecting your life, then those need to be treated. But if you have a Chiari and it's radiologist, it strikes his fancy or her fancy, and they report it, but you're feeling fine, you don't need to have treatment for it. All right. Let me just go into Chiari 0. I'm sort of emphasized the smaller than normal posterior fossa. You can also have Chiari 0 with membranes blocking the CSF flow or scarring blocking the CSF pathways. Sometimes genetic and traumatic and whatever events occur, they can occur together. So you can have genetics plus scarring, or maybe the genetics can cause both small bone and scarring. But anyways, it's not, so you have to be prepared to take care of whatever the pathology is. If it's just bone compression, you can treat that. But if it's scarring, you have to take care of that in the or membranes. You have to take care of that in surgery. Our last speaker talked about basilar invagination. This is just another way to think about it. If you think about the pentagon for the size, with the basilar invagination, with this bone coming up, this reduces the size of the pentagon, especially in the most critical part. Plus, at the foramen magnum, it really tightens the CSF flow and tightens the pathway. So the surgical procedure that we do, you think about the Pentagon, not the Pentagon in Washington, thank goodness. Oh boy, don't think about that. But they do keep us safe, thank goodness. All right, so here's the Pentagon. And here's what we do. Like, I put the Pentagon where it was from before surgery. I put it over here. You can see this extra space that the decompression causes. And that provides both room for CSF flow, and it also allows the brain to take a normal configuration because it has enough space. And this, take about this much bone off, sometimes C1, but only if the tonsils go that low. And you open the dura, and we put in a patch, other people don't. We did morphometrics. Rather than doing our own measurements, now we have a computer do it with this engineer's help. He worked with Frank Loth and measured these areas. But creating this space after surgery is important, expanding the posterior fossa. And by doing that, the cerebellar tonsils go up, and these are very obscure measurements. The CSF pathways become larger. And as far as performance, pretty much most of the improvement in our patients occurs 1 year after surgery as far as performance, less pain, and less neurotrophic pain. This was a mixture of patients with just Chiari and Chiari with syrinx. So I had a lot of splaining to do, and I hope I did it. I think small posterior fossa has underdeveloped bones. It has reduced volume. It can cause displacement of the tonsils, and the treatment will expand that small posterior fossa, and it's usually effective. So thank you very much for your attention.